socially connected through a virtual connection world. Hope everyone's staying safe out there. And I know we're really in just quite unprecedented times, nationally, internationally, so many changes. And so hopefully everyone's keeping their anxiety levels down, sleeping well, trying to stay, connected and exercising out there, and trying to stay sane and digest it all. So I'm really excited to have our speaker here today, Benzi Kluger, who's a friend and such an inspiration for all the things he's doing. Wanted to bring him to our group here today and share some of his wisdom and inspiration. Benzi has moved recently from the University of Colorado, which is where he trained for his residency, over to the University of Rochester. And he joins us he has a dual appointment, both in palliative care there as well as in neurology, and really has an interesting background. So we'll learn a little bit about his journey and about what he's doing, what kind of things he's advocating for, and how he's trying to make a difference for patients. So welcome, Benzi. Thanks for joining us.
Thanks for having me.
So maybe, Benzi, we can start with just learning a little bit of what led you to go into neurology, and then some of the fellowships, because you've had a few fellowship trainings. Maybe you can tell us about what inspired that journey up until fellowship initially.
Yeah, sure. So I guess I started medical school actually thinking I was going to be a psychiatrist, and became really interested in how the brain works. I didn't know anything about neurology before that, and got into neurology. Was very interested in things like free will and Oliver Sacks and all of those kinds of things. And I did what's called behavioral neurology, which is the part of neurology that is most concerned with thinking and memory. And while doing that, I developed an interest in fatigue. I actually developed that during a Kung Fu class. They have you do various things. I don't know if people are familiar with horse, but it's basically holding a squat. And 30 seconds into that squat, I thought my legs were going to explode. And the teacher came by and told me to keep doing it. And when I kept doing it, my legs didn't explode. And it got me curious about where fatigue was coming from. And it looked like a lot of it was coming from my brain and not from my legs. And as I got interested into fatigue, I started learning more about Parkinson's and how big a problem fatigue is for people with Parkinson's. And so I ended up doing a second fellowship in movement disorders. And at that time, I then thought my career was going to be about understanding fatigue and the physiology of fatigue and how that's created in the brain. And then when I finished that and took up my adult job at the University of Colorado, I had a big shift. And that shift happened because when I was a fellow and when I was a resident, if I saw somebody with Parkinson's or corticobasal degeneration or something like that, it was just a snapshot. And I could make that diagnosis, and I could get the right medicine started or whatever. And when I started seeing people long term, it was no longer a snapshot. And I got to see the tragedy of Parkinson's and Alzheimer's and other illnesses play out over time. And it really forced me to confront things that I didn't learn about during my fellowship. Different sources of suffering. How do you keep hope in the face of an illness that's not curable? How do you support caregivers? How do you talk about death and dying? And that kind of led me on my own spiritual journey, and we can talk more about that if we want to, which included Zen Buddhism and spending some time in a monastery. And it also took me into the world of palliative care. And that was really where I've kind of found a home in medicine, is being able to take care of people living with serious illness as opposed to taking care of diseases. So that's kind of how I ended up where I am right now, and I'm really, really happy to be here.
That's amazing. I think we share a lot of those parallels, and some of the people that we brought on this series have been, a little bit more on the spiritual side of things, and not looking at disease as just one, sort of diagnosis like Parkinson's or a symptom like tremor, but really looking at the whole picture, the whole person, and the sort of spiritual, mental, all these different aspects of their well-being. Maybe you could tell us a little bit about that journey with the monastery and how that influenced you. And then I definitely want to hit on some of these other areas. We'll talk about fatigue. We'll talk about hope. And I also want to bring in a little bit of the pieces that you're really doing to around the neuropalliative initiatives and things like that. So we'll hop around a little bit. So stay sort of, we'll have a journey.
Yep, no, that sounds good. Yeah, so the monastery came up, I would say a year or two after I started my adult job at the University of Colorado. And I could actually remember some of the patients that led me to it. I was seeing a woman who had multiple system atrophy, which is kind of a cousin of Parkinson's disease, but worse in a lot of respects. And her husband, had come to see me, and she wasn't depressed. She was just, sad. I didn't even have words for it. In medical school, I learned about depression. I learned how to prescribe Prozac. But this woman actually seemed to have a good reason to be sad and had a good reason to be hopeless. And I didn't have tools for how to deal with that. And I had other patients who were clearly dying of their illness, and I didn't know what to say. I felt as helpless and hopeless as the patient in front of me. Actually, with the woman with MSA, I can remember specifically one visit where her husband was taking her to a medical hypnotist, and this hypnotist was asking her to make positive affirmations in front of a mirror that I'm getting better every day, that I feel good. And I asked her how she felt after she said those affirmations, and she told me, I feel like shit. And and it was just kind of eye-opening for me. And I actually got to the point of wondering if I even went into the right field, because I felt like the things I was offering people wasn't what was really needed to help them. And so I ended up going to a monastery just because I knew a little bit about Buddhism. I knew that it was a religion that took suffering seriously. And while I was at the monastery, a good friend of mine now, Matt Zeppelin, I was working with, and he was a monk who volunteered in hospice. And to me, that was mind-blowing because I was a doctor and hospice was a very scary place for me. And here he was, a monk without any, quote, training, and he was with people who were dying. And I asked him, what did he do? How was he able to do that? And his answer was that, the most important thing was to be present, to be open, and to acknowledge that he too was somebody who was getting old, who was suffering, who had experienced illness, who was dying. And I think in our society, we kind of divide people into, I'm healthy and well, and you're sick and dying. And that can be a very lonely place. And so I think once we kind of remove that barrier and became really open to my own suffering and to my own mortality, I was able to talk to other people more openly about that. And there was actually a real palpable shift in that. And I felt comfortable asking people questions that I didn't feel comfortable asking them before. I could ask people questions about, are you afraid of dying? What's the hardest part of this for you? And I could listen to that and I could be with what they said. And I think that's the key step, because if you can stay present and not run away from it, then you kind of open up the space in the room to help. But if you're closed and if you're looking for an answer and if you're wanting science and medicine and a pharmaceutical to get you out of that jam, then you're kind of stuck. And so that really was a turning point for my career. And it really opened up, I think, not just new ways for me to see the person in front of me, but new ways for me to see myself. And that I no longer had to fit this role, which never was a good fit for me, of being just a doctor. And I could show up as Benzi. And I could bring my past and my knowledge and courage and fears and uncertainties to the visit, in addition to the things I learned in medical school.
Yeah, that's very profound. I remember, Benzi, you and I spoke, and I don't know if you remember this, on the phone a while ago. I think it was about 6 or 7 years ago, where, I had a similar journey where, I've learned what we do well in Parkinson's treatment and what we don't do well. And, was sort of at an impasse of sort of, I feel like there's a lot that we're not doing for our patients, and how do we think about this in a different way? And you told me that you were frustrated by some of the experiences that you had through fellowship, and were sort of feeling like a lot of the time we were telling our patients that, they just had to learn to live with these diseases. It's like, you just have to learn to live with it. But we weren't really giving them tools to be able to live with these diseases or the situation. And I think you wanted to help fix that. I don't know if you remember telling me that, but I found that really inspirational. I think we've brought together a group of like-minded doctors, not just in addressing the issues of our Parkinson's patients under the umbrella of neurology, but trying to figure out how to bring like-minded folks in to help with neurological diseases in general. So I think maybe we could speak a little bit about the Neuropalliative Society and why you think it should exist, maybe define it a little bit, why you think it's an unmet need, and help our patients who are on this call understand how they can maybe advocate for some of these things and get involved.
Sure. Yeah. So so I guess to jump ahead then in this journey, that palliative care, and I know you've talked about palliative care before with this group, but just briefly, it's an approach to care where the goal is to take care of the person in front of you, including spiritual, emotional, social, all aspects of that person. And over the last 20 years, this has become better integrated into cancer care. It's still not where we would want it to be, but if you go to a cancer center anywhere in the country, they're going to have palliative care, and they're probably going to have a summer camp for your kids and a book club and writing clubs and all kinds of things. If you go to a Parkinson's center, the best centers in the country, you don't get any of that. Same thing if you have Alzheimer's disease, even ALS. And so I think the mission of this society is that we need to raise the standard of care for all people affected by neurological illnesses. That includes the person living with the illness, so-called patient. It includes their family, because illnesses like Parkinson's don't just affect one person. It also includes the clinicians, the doctors and nurses, because we're not given the tools, we're not taught the tools that we need to really address this suffering the way that we should. And that's really the central mission of this society. And part of the reason for starting a new society, as everyone on this call knows, is that Parkinson's disease and Alzheimer's and these other illnesses are very different than cancer, and that the needs of somebody with Parkinson's are very different than the needs of somebody with cancer. And so part of the reason for starting this society is to recognize that people living with neurological illnesses really have unique needs, and that we need research, we need clinical programs, we need education, we need advocacy, so that we could best meet those needs. As Indu mentioned, we're getting this society off of the ground. We are intentionally making this society international because we need perspectives from all over the world. We're making it interdisciplinary with nurses and geriatricians and neurologists. And I think very importantly, we're making the society open for people living with these illnesses and their care partners, because that's an essential voice that we need if we're going to do this right. And Indu is part of the society, so as we get things off the ground and we get the website up and we have membership available and meetings, we will absolutely keep everyone on this call informed, because we would love to have you join us, that we think that this is an important movement, that it's likely going to be a grassroots movement. But we're already gaining traction and changing the way we think about and changing the way we take care of people with neurologic disease.
Yeah, that's really important. And how can patients advocate for this more, and maybe tell them a little bit about what you foresee the role of patients in the society as being? Because I know, honestly, Benzi, you and I have done work over the last, I think, 5 years, and when you were in Colorado, you had a tremendous patient advocacy group that you worked with there, and you worked day in and day out with patients to help them guide you, I think, in a very, sort of interconnected way to get care that was needed for patients. And so how do you foresee this being, kind of a symbiotic kind of beautiful thing that patients can feel connected to and help themselves help you?
Yeah. Yeah. So I guess there's a few ways. So one is advocacy. So being involved with the society, I think some people on this call maybe have been involved with the Parkinson's Association PAIR program of patient advocates and research. Um, so there's absolutely room for advocacy, and I think this is an area where we really need to hear the voice of people living with these illnesses. Because as Indy will tell you, I think a lot of the pushback on palliative care, when I give a talk about palliative care, at the end of the talk, people are ready to sign up for it, and they ask me, why isn't this obvious to everyone? Why haven't we done this 20 years ago? And the two answers is, one is, insurance companies, and we have to kind of change the standards and change expectations. And the second one actually is physicians. That a lot of physicians still have, I would say, old-fashioned notions about what palliative care is and hospice and when it should start and who is it for. And so we need to educate them. And part of that will be through the society. And there are actually ways, and we're actually doing this in one of the studies that we're doing right now, that you could come in as an activated patient and help educate your physician. And to give you a few examples of that, when it comes to non-motor symptoms, things like depression, fatigue, pain, those are things that you may need to bring to the attention of your physician. So your doctor may not ask you about those, but if you bring them in, they will be able to handle it. So if your doctor doesn't have a checklist, you come in with the checklist and you make your doctor a better doctor. That's what I mean by being an activated patient. Doctors actually can fill out paperwork for power of attorney, for advance directives. They may not remember to do that. So on your checklist, you can bring that in and you can ask them about it. And if that doctor is not comfortable with that, that starts to become a push for change, because now that doctor, hears that, and maybe is starting to hear that from multiple patients that, hey, I need to start learning more about this. And there are absolutely resources that doctors can learn about that. You might ask for palliative care. You might ask for a palliative care referral. And again, that's going to plant this seed in the doctor that you're seeing, that there's stuff going on that they don't know about. If you're going to certain centers like Colorado, where I was, or Rochester, that the physicians may be on board with that, but I would still say most places in the country are not at that stage. And so I think some of this is going to be a grassroots level. If I could jump ahead a little bit, we just got a very exciting grant from the Patient-Centered Outcomes Research Institute. What this grant is we're partnered with the Parkinson's Foundation to make palliative care the standard for all of their centers of excellence across the world. And I think over the next 3 years through this grant, that's really going to be transformative to making this a new standard for the whole field, because those are where people train. Those are where, over 200,000 Americans get their care. They're really the leaders in their region. So I think this is really happening. And we definitely need the patient and care partner voice to let physicians know that not only is this okay, this is what we want. Because I think a lot of times doctors are afraid that if they bring up palliative care or if they bring up advance directives, that they're going to take away your hope. And my experience has always been, when I bring up these topics, people feel relieved, they feel heard, they feel seen. And I think you have to let your doctors know and to encourage them that this is actually the right direction for them to go.
That sounds good. Now, Benzi, you not only talk about this from a clinical perspective, but you've also been doing some pretty groundbreaking research. I'd like you to tell us a little bit about the PCORI study and the publication in I believe it was JAMA Neurology.
Right.
And then maybe you can talk about, a little bit about the future of that kind of research.
Yeah, absolutely. So I think it was in 2014. So we had started our clinic in 2013. We did a couple of studies that showed that people living with Parkinson's disease had palliative care needs that were actually at the same level as patients with cancer, and that these palliative care needs, things like spiritual well-being, like grief, like symptom burden, contributed to that patient and their caregiver's quality of life. And so if our goal as a movement disorder society is to optimize quality of life, we are not going to get there if we don't address palliative care. And so that became the foundation for us to write a grant, which we got, to do a randomized controlled trial where we compared outpatient palliative care. So that included a neurologist who was doing palliative care, and a nurse and a social worker and a chaplain, um, to standard care, which is you see your movement disorder doctor, you see your primary care physician, and then whatever else happens is what happens. And our contention was that by having an organized team, that things were not going to fall between the cracks as much, and that patients were going to have a better quality of life, and that care partners were going to also do better. We felt that under usual care, that when it came to things like spiritual well-being and care partner support and difficult emotions, that the care partner and the patient were kind of on their own to figure things out, and that they might get lucky and find a good support group or a social worker, but more often than not, they didn't find those resources. And so at the end of the day, when we compared the results of this study, I would say the outcomes were overwhelmingly favorable for palliative care. Patients had better quality of life, caregivers had less burden, caregivers had less anxiety, patients had better treatment for their non-motor symptoms like pain and constipation and depression. Patients had better spiritual well-being and grief. They did a better job with completing advanced care plans. So we really showed, I think, pretty definitively what we all knew, which is that palliative care is a good idea for people with Parkinson's. And so I think the question now is not if palliative care is the right thing to do for people with Parkinson's, but how do we do it and how do we do more of it? So we're right now in the middle of a study that's funded by the NIH, which is a community-based study in which we are training neurologists in the community. There are 20 neurologists actually in Colorado and Wyoming and California, some of them in rural areas, and we're training them how to do palliative care. And then we're using virtual house calls, so telemedicine, to provide chaplain and social work and other support for their patients. And we're about 4 years into that study, so we're almost done with the study, and then we'll have the results. I can tell you that qualitatively, so before looking at the data, that both patients and neurologists really like the study. I think people are really getting a lot out of it. When we started the study, actually, telemedicine wasn't as common as it is right now. So COVID, coronavirus has really kind of accelerated things in a direction that we were going anyway. We were already going in this direction 3 years ago. But I think it's accelerated it. And we'll see. We'll see if this model of care can work. And if it does work, this is another thing that the Parkinson's Foundation has committed to supporting. So they would also commit to supporting, providing this extra layer of support through their centers of excellence. So we're excited about that. But I think that's really kind of the next frontier with neuropalliative care is how do we make this the new standard? Because not everybody is going to be able to get their care at the University of Colorado or at the University of Rochester. So how do we develop models of care that allow us to give the highest care, the highest person-centered care possible to everybody without forcing people to travel to these academic centers?
So there's been a few comments here. I just want to take a minute to read them, Benzi. Unfortunately, palliative care is usually associated with end of life is one that Ken brings up. And then Hetty says, most hospitals at present have a computer system. Each one should devote a screen to Parkinson's disease and its particular needs. Kind of like you were talking about, maybe like a checklist, both the ER and the units. Something about Munson Community Hospital, where she lives in Traverse, and is trying to implement such a system. And I think that speaks to the electronic medical records and possibly having, ways to have triggers to ask these questions. And then Sylvia asks, at what point in the Parkinson's disease process would you suggest the patient to be on a palliative care program?
Yeah, so I
maybe you could just address a couple of those.
Yeah, absolutely. And so for Ken's point, absolutely, and this is one of the biggest barriers, I think, with both patients, but more so with physicians, is this idea that palliative care is the right time is end of life. And we really need to break that association. So one of the things that we found actually in our research, and maybe some people on this call may resonate with it, is that the time of diagnosis is actually a time where there are a lot of palliative care needs. That people are confused, they're grieving, there's a lot of changes in their life, they need help with planning. And so we really need to think about palliative care as something that's proactive. When I give talks about this, I'll sometimes show a slide which is a Calvin and Hobbes cartoon in which Calvin is waiting for inspiration to do his homework, and Hobbes asks him, how will you know when you're inspired? And his answer is last minute panic. And that's kind of our current system of palliative care, is that we don't do anything, and then at the last minute we try to do everything. And that's not a great way to do palliative care. That we can't unburn out a caregiver after they've burnt out, that we can't, turn back the clocks and allow people to spend the last 3 months of their life at home rather than coming in and out of the hospital. So we really need to reinforce that message that palliative care starts at diagnosis. Palliative care doesn't start 2 days before someone's about to die. I think Hetty's comment is awesome, and it really reinforces the power that patients can have as advocates. And I think we had a similar thing at the University of Colorado where there was a problem that Parkinson's patients weren't getting their medications on time in the hospital. And so this is something where I think patients can really push the hospital and push doctors to try to change their systems to make things systematic. And I think one of the things we learned from our studies is that we need checklists. When we started our study, I was a typical arrogant physician and felt like everyone else in the study needed a checklist, but I didn't. And I would say within a few weeks of being in the study, I was really glad to have a checklist because it meant that I didn't miss things. So we want all these things to be systematic, and this is something that caregivers and patients can absolutely advocate for. And I would say, at what point in Parkinson's disease would people be on palliative care? This is something I've actually been thinking a lot about, is that we kind of have to also get outside of this mindset that palliative care is not, it's not like penicillin. It's not like palliative care is just this thing, or like a Big and Loud program or something, that it's one size fits all. That palliative care is an approach to meeting the needs of the person in front of us. And so palliative care is going to look different depending on where you are on your journey. But I think at every point of the journey, having a palliative care approach can be helpful. And that's different than saying that you have to see a palliative care clinic. And so this is part of our educational work, is trying to help physicians and support groups and social workers and chaplains use the palliative care approach to help people no matter where they are in their journey. There may be a time, if people have a lot of complex symptoms, if they're nearing the end of life, where seeing a palliative care clinic makes sense. But certainly at the time of diagnosis, if your doctor can do a good job with providing your diagnosis with compassion, if they can talk to you about the future, if they can connect you to support groups, you don't need a special palliative care team. And the idea is that not everyone needs a palliative care team in every visit, but that everybody needs a palliative care approach. And so it's really kind of a paradigm shift and changing the way that we think about Parkinson's more than it is a clinic that everybody needs to go to.
Yep. We can address some of these.
Go ahead.
Yeah, no, so I think just to sort of understand a little bit better. So I think one of the problems is that palliative care has been so connected with the word hospice and end of life that it becomes like this continuum that everybody thinks is like, this last ditch effort when there's no other treatments, that suddenly it's we switch the teams and everybody hands off to this other team, and it's really not that. It's sort of this approach that should be educated through healthcare training for all healthcare providers, which is this more holistic approach to not just the disease, but sort of the person in sort of the framework in which they're living, and the complete person, not just their physical, but mental, spiritual, and all these things. And then this approach is important to sort of revisit through different sort of points from diagnosis in sort of visits throughout, and may become more intense at certain times, maybe when there's a crisis or a non-motor issue that comes up. And then as a sort of team gets to know one another, and as things progress, hospice is a very different sort of role, which is sort of the last 6 months or a year of life. And I think Farah described that a little bit. And Dr. Katz-Maya has also spoken about, some of these approaches as she's seen them. So I think that's very helpful. Benzi, I want to give you some time to talk about fatigue, because I think that's really something that you've done some, has been an interest of yours. It sounds like even through this, the squat that you were doing in Kung Fu class or whatever. So maybe you can tell us a little bit about fatigue as you define it. Maybe tell us a little bit about approaches to helping it, not just from the standard, playbook that we all get taught in Western medicine, but maybe even some of the thoughts that you have as a more spiritual and well-rounded kind of person living on our planet.
Sure. Yeah, so fatigue, as I said, was one of my early interests, and it continues to be an interest for me. About 3 years ago now, the Parkinson's Foundation held an international working group, which I was a part of. And one of the things that came out of that, which is something that you could look up, is a definition of Parkinson's disease-related fatigue. And part of the reason why we wanted that definition out there is that people don't recognize how big a problem fatigue is for somebody with Parkinson's. Fatigue kind of falls under this invisible symptom. People can't see it like they can see your tremor, and it's very misunderstood. We actually just finished a study, which is under review, where we talked to people with fatigue, and one of their number one requests was for people around them to understand that fatigue really wasn't their fault. That I think there's this idea that when people have fatigue, it's because they're lazy, or they're not able to tough it through, or it's a sleep problem, or it's depression. But fatigue and Parkinson's is something totally different. And people I've talked to who have fatigue with Parkinson's, everyone's had fatigue at some point in their life. But fatigue with Parkinson's is kind of more like you have a really bad flu. So when you have the flu, you can take a nap, you wake up from the nap, you don't feel tired or sleepy, but you still don't have energy to do the things that you need to do. And that's more what Parkinson's fatigue is like. Parkinson's fatigue can interfere with doing things day to day. It can make it difficult to do exercise, or if you do exercise, then you have to pay the price for being in bed for 3 days. So Parkinson's fatigue is a big deal. It's actually the number one symptom that leads to disability claims in Parkinson's disease is fatigue. So I really want to make sure that we have it on the map. There are some common causes of fatigue that we want to make sure that we don't miss. So there are sometimes secondary causes of fatigue. One of those can be medications. So some medications can cause sleepiness or fatigue. That includes both Parkinson's medication, some blood pressure medications. Dehydration or low blood pressure can cause fatigue. Vitamin deficiencies like vitamin B12 or vitamin D, low testosterone or low thyroid hormone, anemia. Sleep apnea, even though it's usually causes sleepiness, can be associated with fatigue. So those are, getting a sleep study. So those are places that I would often start to make sure that we're not missing another cause of fatigue. When I talk to people about fatigue, I like to understand when it comes up and what the pattern of it is. For some people, the biggest part of fatigue has to do with concentration and mental fatigue. And for some of those people, using a stimulant, a medication like methylphenidate or Ritalin, the same medicine we use for ADHD, can sometimes help quite a bit. So that's one trick that I will sometimes use. Power naps is something that can be helpful for some people. So there's going to be natural rises and lulls in energy, and you can plan your day around that. A lot of times right after lunch is a great time for a power nap. And then you can get up from your power nap, I would say no more than 30 to 60 minutes, and get on with your day. One of our things of research that we found patients say, and I think is useful and maybe worth looking into, is sometimes a small snack can help with fatigue. Sometimes doing activities that are meaningful can actually help with fatigue. So we found that certain people, if they were feeling fatigue, if they could get into some music, get into a piece of art, or exercise, something that was really meaningful to them, that they could push through their fatigue. That's not true for everybody. I think one of the things that's also clear from our research, and we're also working on another paper on this, is that everybody with fatigue is not the same. And that for some people, exercise helps their fatigue, for others, it hurts it. And so one of the things that we're trying to also look into is trying to distinguish different kinds of fatigue. And the idea is that I think some people with fatigue, it may really be driven by a sleep problem. Some it may be associated with depression. And for some people, particularly younger people with fatigue, we think that it's kind of its own disorder. and that we're doing research. We actually just published a paper showing that in those patients, that fatigue seems to affect different parts of the brain than people with depression or sleep problems. And so I think there's a lot more work that needs to be done. I mean, and then that's actually a big area of advocacy for me right now, is that if we think about things like depression or pain, which are also subjective symptoms, because of the science that's been done, we now have a lot of tools to treat those symptoms. But as of yet, depression is still something that has, or fatigue is still something that has a lot of stigma around it. And so again, I think we have to work to get the science more solid, and also to reinforce this with physicians that fatigue actually is a serious problem and that we need better tools to treat it. As Indu hinted at, we did do one study of acupuncture, which suggested that it could be helpful. There was a study in MS showing that mindfulness could be helpful. There's various other energy management strategies. Strength training actually seems to be potentially more helpful than other types of exercise. So I think there's a lot of tools that we can work with, but again, there haven't been enough studies right now that anyone has a really complete tool set.
Okay, that's helpful. So let's talk a little bit about that acupuncture study. And I also want you to tell me a little bit about, as we'll get into with the acupuncture study, placebo effect, and also maybe you could define in your own words a little bit about the non-specific effects that you mentioned in that
Sure.
sort of explanation.
Yeah, so the study that Indu's mentioning was a study that we did with the Michael J. Fox Foundation grant. And we randomized people who had Parkinson's disease and moderate to severe fatigue, so fatigue that was severe enough that it was interfering with their day-to-day life, to either get real acupuncture or placebo sham acupuncture. And the way we did the sham acupuncture, and if people have had acupuncture before, they'll know what I'm talking about. Before I got acupuncture, I was afraid of it because I don't like getting poked with needles, and I thought it was going to be painful and like getting a bunch of shots. But the needles in acupuncture are really very fine. And so it feels really more like just a pinch at the skin. And so the way we did our sham was we used a sharp toothpick. The patient was blindfolded, and we used a sharp toothpick, and we poked away from the real acupuncture points. And people did not know what group they were in. So we did a good job of blinding. Also, at the end of acupuncture, we again kind of poked people and took out the fake needle and threw it in a sharp spin so people would hear that. So we did actually a really good job with our sham. And what we found at the end of the day was two things. One was that acupuncture helped people with fatigue. And about half of the people who took part in the study, including people who had tried Ritalin and other medications and whatnot, felt their fatigue was significantly better. The other important finding was that it didn't matter whether it was real acupuncture or the sham. And so it got us to thinking, that sham acupuncture is more than nothing. So people in the sham acupuncture group were having to go in twice a week. They were focused on their body. They had this intention to get over their fatigue. When I started the study, I actually had kind of a naive idea that if people in the placebo group got better, that we would just tell them that they got placebo and their fatigue would go away. And that's not what happened. That people in the placebo group actually had to go back and see a real acupuncturist in order to maintain those benefits. So the placebo effect and these non-specific effects are interesting. One of the things I think it suggests is that our unconscious mind has a lot more power than we typically give it credit to. And there have been some very interesting studies of placebo with Parkinson's showing that with placebo, so giving people placebo Cinemet or placebo DBS, that people can increase dopamine in their brain up to 40 to 60%. So there's an enormous amount of power there, but it's a power that we can't tap into directly, at least not typically. And so it's got me, very interested. I'd love to do a study on mindfulness. I would love to do some other studies to see if there are ways that people can learn how to tap into that potential more directly. Exercise is certainly one way that people can do it. But the placebo effect, is not as straightforward as people think. It's not just expectation. You can tell somebody you're giving them a placebo and they still get a placebo effect. So it's definitely a pretty complex area, and one where people are actually doing, I think, some very interesting research, and it's again an area where I think there's huge untapped therapeutic potential.
Yeah, absolutely. There's a question or two about defining fatigue and diagnosing it.
Yeah,
Could you tell us a little bit about, how you're measuring it? What actually was the definition that you ended up? You said something about, like a flu, kind of the feeling that you get, like sort of
yeah.
that. But is there more of a layman's definition or a scientific definition that you guys used in this paper and in the study?
Yeah, there absolutely is. And one of the analogies I'll use is the difference between being sad and depression. So all of us feel sad from time to time, but clinical depression, depression where you are down for 2 weeks and you can't get out of it, is very different. And I think one of the things about fatigue that makes it difficult is that we use the same word fatigue to mean a lot of different things. That we use fatigue to mean tired, that we use fatigue to mean how we feel after we work out, and we also use the same word fatigue to mean somebody with Parkinson's disease who can't do what they used to be able to do because of this fatigue. And so the way we defined it was, number one, for somebody to have Parkinson's disease related fatigue, they had to have fatigue that was so severe that it was interfering with their ability to do day-to-day activities. So that's one part of the definition. A second part is to make sure that we're clear about what we mean by fatigue, and that we don't mean depression, we don't mean sleepiness, we mean a lack of energy or a lack of ability to get ourselves to do things. And that's also different than apathy. So with apathy, people don't have motivation. With fatigue, people have the motivation, they just don't have the energy to do it. And so that's what we mean by fatigue. And it's important that we distinguish it from depression or sleepiness or apathy, because those are different things that have different treatments. So I think those are the two big components in a nutshell, is that it's a problem with energy that interferes with your day-to-day life, and that it's not depression, fatigue, or any of these other secondary things like low testosterone or low B12 or low blood pressure that would be potentially treatable.
Okay, that's helpful. So I think there's been in the chat some resources put up, and we'll link those, including your statement about fatigue, with the Parkinson Foundation, and some of these approaches. One question is that of the checklist, harkening back to the checklist about the things to check in with around the palliative care, you know, symptoms, approaches, and also the non-motor symptoms, and even the advanced care planning piece and checklists to help guide patients to trigger their doctor to handle these. Is there a central place or a resource that you know of that could help with this? And if so, maybe you could give us some resources verbally now, and then we can link them as well.
So there are a few resources out there that are great for advanced care planning. One of those is called prepareforyourcare.org. One is the Conversation Project. One is called Go Wish. And so those are excellent. As far as the checklist goes, for symptoms and for some of the other things specific for Parkinson's disease, that does not exist yet. If people wanted to, both in the JAMA paper, which Indu can send a link about, and in some other papers I actually wrote an implementation of palliative care paper. There are checklists for what the physician and the social worker and other people are supposed to do, and you could extrapolate from those checklists to make your own checklist. One of the things, and I don't know if Indu's talked about this or has plans to talk about it, but I think it may be worthwhile to think about, kind of having a checklist for doctor's visits and how do you get the most out of your visit. And there are out there, and again, I'm not the biggest expert on this, there are what are called QPLs, or question prompt lists, that are out there that are made to help, really, they're made to help patients make their doctors better doctors. And again, as far as I know, I don't think anyone's done this specifically for Parkinson's disease, but somebody should. And your question, definitely reinforces to me, actually, as me and Indu work on this for the Neuropalliative Care Society, I think one of the things that our website could provide would be checklists for patients to get more out of their neurology visits, and checklists for patients to be able to make their doctors take on a palliative care approach, even if they didn't have that on their agenda. So as an activated patient, you bring the agenda and you get your doctor to do a better job than they might have done without you being so active and engaged.
Yeah, absolutely. I think those are unmet needs, and this is sort of why we're talking to patients, is sort of to find out what your needs are and how we can try to help meet them. So the fancy fingers of the PMD Alliance have put the Go Wish, for your care, the Conversation Project links. Somebody also mentioned the 5 wishes. And the Davis Finney Foundation apparently does have some checklists, but I think those should be revisited, and I'm happy to help work on that with you, Benzi. And I mean, not just in Parkinson's, probably there's a need in many other diseases and neurology as well. I want to spend, go ahead.
One thing, if I could,
Yeah.
another link, if we could provide it. So Kirk Hall, who I don't know if you ever had on the show, but he has a great blog. He actually has 2 children's books about Grandpa Shaky Paws. But he published a journal in NPJ Parkinson's disease on a patient's perspective on palliative care. And I think he has checklists in that article, and that article is also free and open access. So maybe we could also provide a link to that one.
Yeah, I think by starting the links and seeing what we have already, maybe we can see what's needing to be done. So I think that's great. Well, Benzi, I think we have about 13 minutes or so to share some more wisdom of yours. I wanted to give you a space now to talk a little bit about joy and the concept of positive medicine, because I am really all about silver linings and positive, perspectives, and trying to find, joy and purpose has been something that I've really been speaking more about in my definition of health to patients. And so I want to hear that, your concepts and a little bit of your ideas.
Yeah, thanks for asking that question. So, my journey in palliative care has had all kinds of wonderful surprises, and one of them has absolutely been joy. And it actually, I think, came up for the first time in kind of a surprising context, that we had a woman that we were taking care of who had cortical basal degeneration. And in Colorado, where I was working at the time, we had medical aid in dying, and she made a request for medical aid in dying. And our chaplain, just to explore that and to understand where her suffering was coming from, asked her if there were things that she still enjoyed. And she said being around family. And then he asked her, well, how much more time would you like to spend with family? And, and her eyes lit up as if he was an idiot and said, a lot more time, you fool. And what we realized is she actually changed her mind and ended up deciding that she wanted to do hospice at that time rather than medical aid in dying. And it was just this very empowering moment, I think, for our team to hear that we really should be spending a lot more time than we are looking for opportunities for joy. And since that time, we purposely, we have this on our checklist, absolutely. In addition to looking at sources of suffering, we look for opportunities for joy. And that's looked, for some people, actually there's a woman I remember with quadriplegia who we got skydiving because that was important to her. We've had RVs modified so that people can continue to travel. Sometimes it's simple things like encouraging people to eat more of their favorite food, encouraging people to listen to more of their favorite music, to catch a sunrise, to hold hands, to tell stories with their loved ones. But there's really this kind of untapped potential out there. And I think kind of ironically, with COVID, I think one of the silver linings is that people are really recognizing the importance of joy in their lives. That the New York Times has a new series about joy. Actually, with burnout in medicine, there's been a lot more attention paid to joy. And so joy kind of becomes the secret weapon that we can use when we have an incurable illness. So I can't, cure your Parkinson's disease, but what we could hopefully do together is if you have a year or 2 years or 5 years, we can really work hard to make that the most meaningful and the most joyful and loving and connected time of your life. And we can try to get a family reunion. There's actually a great article in the New York Times and also in journal, I think it was in Palliative and Symptom Management, that had people asking patients about what's on their bucket list and using that question as a way to prioritize the care we provide. Because if your bucket list includes going to Ireland or going to Australia or skydiving or whatever, there's no better time than the present to do that. If you have a progressive disease, there's no better time than the present, and it may bring up things that may not be possible, but maybe we could modify them to make them more possible. So maybe you can't, hike a 14er, but we could spend more time in the mountains, or you can spend time sitting in front of your favorite lake in nature or other things. And so, yeah, so it really got me thinking, and that's really, I think, become incorporated into our philosophy for both patients and family is to not only focus on suffering, and suffering is important, and I don't want to whitewash it or make it sound like suffering doesn't have grief and suffering doesn't happen with Parkinson's, because it does, and we need to acknowledge that. We can't ignore it. But suffering and joy can coexist, and joy can make suffering easier to bear. And so I think it's really important that we consciously and intentionally bring joy into the conversation.
Absolutely. I know, Benzi, you've spent a lot of time talking about caregivers as well, and a lot of your focus has been on them and, how important it is. And, we've talked about that. Could you, in the last maybe few minutes, and I'm going to give you a few minutes of just, inspiration and closure as well, just spend a little time telling us, your pearls maybe towards approaches for caregivers. And there are a number of caregivers on the call as well. So if you could just, tell us a little bit about your thoughts on that.
Yeah, so for caregivers, or oftentimes, like the term care partners,
Mhm.
that were, kind of partners in doing these things together. A few things to think about. One, again, with the positive side is thinking about, and this is true for patients, how do you want to grow through this illness? So are there opportunities for you to grow? Are there ways that you can find meaning along this journey? Are there places where you can find joy along this journey? Are there places where you can find grace or spiritual growth? So I think those are really important questions to ask and can be empowering, because a lot of times if you're a care partner, I mean, you certainly didn't sign up for this. This wasn't the plan, even though you might have said until death do us part in sickness and in health, but not this kind of sickness. Um, so we didn't sign up for this, but we still have opportunities here. Second, I think it is to reach out for help. That this is not a sprint; it's a marathon. That if you burn out, everything's going to fall apart. So it's really important that you make time and effort for your self-care. And that could be, taking in a few hours a week to do something that's meaningful to you, to just take a vacation from your life, to sit by a lake, to have a therapist, to talk to friends. But really important that you find ways that you can recharge. That nobody wants or expects you to be perfect or selfless. One of the things that's actually a source of joy for me is seeing how friends, neighbors, families will come out of the woodworks to help you if you just ask. And I think a lot of times we have this mindset, particularly in America, where everyone's supposed to be so damn independent, that nobody wants to help. But people are dying to help. And it's amazing to me. I mean, it's lovely to me to hear about how neighborhoods and families and others have come together to help caregivers when they just asked. And I think part of that, and which is a difficult thing, is kind of finding this practice of grace and acceptance. And that being able to accept help can be as big of a gift, sometimes even more so, than giving help. And so being able to accept help and being able to do so gracefully really helps this other person. And so it's not even a matter of putting our pride aside, it's just developing a different kind of grace when we approach that.
Absolutely. I think so much of what we have talked about, sometimes when I talk to caregivers, they feel guilty about taking pleasure and joy in things. There's this,
Right.
Tremendous guilt about needing to be in the moment of suffering at all times. And there's a way to be present, but not take all of that and then, breathe and live that all day long. It's important for you to recharge
Yeah.
rebuild and share these beautiful things that life has to offer with, gratitude and grace and joy. I mean, these are words that, are emotions that are so so important, along with the sort of, guilt and sadness and, anger and all the other things. And I think sometimes just pausing to identify the mix of emotions that one can have, and we've been doing some of this with COVID, is, just sort of sitting even with our students or our trainees and saying, how are you feeling? And sometimes it's positive emotions mixed in with negative emotions, and just being able to understand all of what we're processing is tremendously helpful. And I think for our caregivers, just to hear that sort of self-care. And I know, Benzi, you and I have been talking even as healthcare providers about taking time for ourselves to care for ourselves, even, and it is hard, when we give so much to just, protect and take care of some time for ourselves. And I think this is something that you and I have just been trying to drizzle in our own lives. And so I think, being cheerleaders for our patients and our care partners to do the same is so important. It's not something to feel guilty or self-indulgent. It's really just to take care of yourself so you can take care of our lovely patients. So I think that's absolutely important. So it says a few questions. Everyone's been very positive about this so far. Myra says, seems like we should start meetings by asking what puts a smile on your face, then encouraging folks to continue to add the activities that provide the happiness. I mean, I think this COVID timeframe, and I'll give you a minute to speak on maybe the silver linings that you're seeing of that, is giving us a minute to pause to really sort of reflect on the things that are important, that bring us joy and meaning, and to connect with people that are absolutely important to us, as you were mentioning. So tell me a little bit about what you're taking away from this COVID timeframe, and some silver linings and sort of some hope, maybe a message or two of hope for the future as well for our patients and carers out there.
Yeah, there have been a few kind of unexpected things that have happened with COVID. One is I think it's really, in a lot of ways, across society, has kind of opened our eyes to what's possible. So for years, telemedicine has been possible. And there's been various things of red tape and whatnot that have gotten in the way. And then COVID happens, and all of a sudden we're doing telemedicine. And I think that in and of itself is great. That's moving the needle forward, and it's allowing us to provide care in the home and provide care in creative new ways that we hadn't before. Another silver lining that's come out of this, which is, again, maybe surprising, it doesn't get as much attention on the news, is that palliative care has really gotten a huge boost through COVID. We hear all about, frontline workers and ventilators and ER physicians, but palliative care physicians have been essential during the COVID pandemic, right from the get-go. That the ICU doctors were needing help of, how do we help people who are dying of COVID? How do we help their families who may not be able to be present there? How do we keep people out of the hospital? How do we help address some of the worries that people have about going to the hospital? As I've been doing care for people, I know COVID has put a lot of strain on both patients and caregivers, and I think has increased our need as a healthcare organization to provide better caregiver support, because a lot of the typical ways that we supported caregivers, like adult daycare and family and friends visiting, are no longer present. So I think in some ways, COVID is kind of accelerating, a lot of the change that I was hoping to happen over time. And this is, not the way that I would have wanted it to play out. Nonetheless, as one of my mentors said, never waste a crisis. So we'll take advantage of it, and we'll continue to push forward.
That's great. Well, thank you so much, Benzi. This has been so amazing to have you on. I've wanted to have you on for a while, and you're just an inspiration in so many ways, not just with your logical thought process of how to approach things, but you're, really trying to change things from, I think, the foundation. So doing the research painstakingly, writing the grants to get this type of research done, but also in your day-to-day inspiration from an educational perspective as a mentor and leader in this field. And also as somebody who, as a friend and a patient advocate, that I can really reach out to and say, how can we approach this differently? And you always have, a sense of how to get things done in a, sort of very holistic and beautiful way. So I really appreciate that. And I think that there's been a few comments here, and from Joanne. I'll just read this last one, and then we'll hand it back to the PMD gang. I can fully appreciate and want to thank both you and Benzi on the comments made on positivity and silver lining recognition. Thank you for that. So I think, you know, patients are really looking to have some acknowledgement of many of these things that they've been thinking, and also some hope and joy that we can bring to them as well. So I really appreciate that. So handing it back to you guys at PMD Alliance for our goodbye wave and any other sort of notes on our future. We have some really amazing speakers. Ray Chowdhury is joining us from the UK. We have speakers from Australia, and on Friday with Simon Lewis. So really, you know, try to join us. We've put out the call for speakers and no one's turned me down yet. So I'm just so excited because I think this is such a meaningful group, and I think we'll, you know, share the videos on YouTube as well, and we'll continue to build the momentum for positivity and change.
Awesome. Well, thank you very much, Dr. Kluger and Dr. Subramanian. Thank you everyone for joining us today. There was a lot of fantastic nuggets in today's session. So we look forward to seeing you at our next ones coming up, and let's do our wave goodbye to everybody. See you. Thanks for joining.
Thank you.
Thanks.